Hey everybody, we're going to talk today at the October in-service about disaster planning. We're going to talk about the new process with Survey. We do have a new process with Survey starting November 28th this year. That process will include a couple things that we have to go over as a group so that we could kind of change the ways that we do things moving forward. And we're going to start off with that with talking about some new wording. One of the wording that we've used quite frequently is the word emergency contact. The state has seen this as a term they don't want to have in the medical records. We're going to replace that term with the term resident representative when applicable. We won't always be able to do that. Certain parts of our medical records won't allow us to change the word emergency contact, but we're going to add / resident representative. So, with that being said, we could still state family, friend information. Maybe it's a brother, a cousin, or a husband or a wife, but we want to make sure that we include those individuals as resident representatives, not emergency contacts. So make sure you're on the lookout for that. We'll also be looking at some other terms. One of those terms is non-compliant. The term non-compliant is seen as an end-all be-all, and that's not what we want it to be. We want the term non-compliant to be a catalyst for how we're going to invoke some changes, whether that be a resident's preference, whether it be some of their background, but we want to try to accommodate. So instead of using the word non-compliant, we would want to say the person did not want to do whatever we were asking them to do, but when we talked to them, it was because it was either too early in the morning, maybe too late at night, it wasn't good for them at that time, they didn't feel up to it. They would simply want to see reasons behind the refusals. So it is going to be imperative that moving forward that we are documenting why the refusal, not simply non-compliant. Dental. This came up at last month's in-service. Dental is very important. It's something that they're focusing on for a resident rights perspective. They're stating, obviously, if people do not have a good dentition, then they won't be able to eat, and it could lead to a decline in their health. We do this already, but we want to ensure that anytime someone loses either their own teeth or their dentures, that we are addressing their diet immediately. Their diet should be addressed from maybe a mechanical soft to a puree, or maybe from a regular to a mechanical soft. This is something that nursing would have to address immediately. There is a rule that we have to notify the dentist within 3 days. That's 3 days. We have to notify the dentist that we have someone that is going to need new dentures or have their dentition addressed. It does not mean that has to be completely addressed within 3 days, simply that we notify. A log will be held by the Social Service Department on our SharePoint so that we can keep track of this for the state. So we look to the staff for responsibilities. We look to them to look over and be ready when state comes in to answer questions. Recently, Paige Larney has been going around and testing many of the staff, giving them small cards to put into your name badges so that they could go on key topics of elder abuse, QAPI, disaster preparedness. It is imperative that you're attending these in-services because these are all questions that you're going to need to know when the state comes in the building and asks you these questions. You have to know what RACE stands for, what PASS stands for. All this will be on a laminated card. If you do not have one of those cards and you've not been tested, please make sure to see Dan, Chris, Sue, or Paige. Social media, this is always a hot topic, and recently many facilities have undergone large lawsuits in regards to staff posting pictures of social media and residents on social media. It is a great rule of thumb to not include work in your social media. You never know who may have a resident in our facility or know someone that's in the facility. It is not good business, and it is not allowed by the Village at Marymount for you to post anything referencing your job on social media. So please, please, please do not do that. If you would like something to be posted through social media, please go to Ron Hollowell, our social media director, and he can assist you in making sure it's posted onto our website. In news, many of you know we did a pilot program with we actually did it through Medtronic over the last year, where we had a number of patients that received a new type of therapy called Neuro. And what it is small stimulation that's given to the tibial nerve of a patient that will help them with their bladder incontinence. We've done this with assisted living. We did this in Villa St. Joseph as well. Currently, we have about 8 patients that are on this program. Sarah Mathis, part of our outpatient therapy group here, has been assisting in this process. Because we brought this new technology into long-term care and assisted living that did not currently exist, we were awarded the Silver Award through McKnight's in conjunction with Medtronic. We will be looking at more individuals that we'd like to bring onto this program starting in the upcoming months, so please keep an eye out for this, and it's definitely an interesting topic you could talk to with your coworkers. Disaster preparedness. This is the crux of what we are here for. It is very important that we know how to prepare and be ready for a disaster. We have locations of where each emergency policy and procedure book will be located. We have one at each of the 4 nurses stations, one in Marymount Place, one in Dan's office, and one in Sue's office. These books are large books, but do not be intimidated because we made them very reader-friendly and user-friendly. We really wanted to emphasize that these policies and procedures are working policies and procedures. We had to come up with a number of top-rated risks for this facility, and in order to do so, we used the Kaiser Permanente standardized tool to help us assess our vulnerability. From that, we were able to look at all types of disasters and find our top 10. As you would expect, our facility has different disasters than maybe a facility in Florida or maybe a facility in California. From that, we did receive our top 10. In that top 10, we found fire, tornado, epidemic, like a flu, active shooter, elopement, power outage, generator failure, bomb threats, temperature, extreme weather, hazmat incidents, including chemical spills, and cyber attack. When you gauge these disasters, you also have to understand the risk of life loss. That is why things like active shooter have crept up high onto this list, because there could be the possibility of life loss. Whereas cyber attack falls a little bit lower on our list because it truly would not impact lives. Additional vulnerability assessments also had to be completed. Along with the Kaiser tool, we did the National Fire Protection Association 99-2012 tool. The NFPA 99 tool helped us to look at facility systems. This looked at our gas-powered devices, vacuum-assisted devices, electronic systems, HVAC systems, electrical equipment throughout the building. What would happen in the event of emergency? How would these work? Would they fail? What do we need to make sure that these are running for the well-being of our residents that we serve? From all those disasters, we had to create policies and procedures. We developed policies and procedures for each one. Again, emphasizing that these are very readable policies and procedures, that when you pick up that book, you could simply start going through the process of looking at each and every disaster and what we should do. We also had to develop policies for sheltering in place and evacuation, specific to our facility and how we would handle them. So this is not a generic format. This has definitely been made strictly for our building in mind. We have a simple policy statement. Villa St. Joseph is committed to planning, preparing, and training for disasters specific to our resident population and the facility. Planning will be completed using the guidelines from the Ohio Department of Health. This means we will be having drills. We will be periodically educating all the staff on the information, and we will be updating these as things change throughout the years. Communication plan. This was another key part of what we had to do. When we work on our communication plan, we had to work with local fire departments, emergency management agencies, Marymount Hospital, to try to make this work for our facility and for the city. We had to develop a communication plan with other nursing homes. We also had to come up with a nursing home incident command communication. Individuals will have specific jobs and roles if in fact a disaster does occur. We will go through that a little bit later in the presentation. I'm going to hand this off to Bill so he could talk about sheltering in place.
Thanks, Dan. So there's been a lot of information presented about disasters, and I know it can seem very complex, but if there's two key points I'd like you to walk away with today, and the first being that our goal is to keep our residents safe from harm. That's really our main objective when there's a disaster and there's a fire or a tornado, whatever the disaster may be. That's not as important as how it affects the building and it affects our residents. So really step one is keeping our residents safe. And the other really important key factor is after the disaster, we still are going to have to care for those residents at the same level of care that they were receiving before. So that's really the two big goals for us with any disaster. And that's what I want to emphasize, which is if you don't remember every little detail about the plan or about the policies or what do we do in a bomb threat, really the goals are to keep the residents safe and then provide care for them after the incident. So shelter in place, that's really our first and best option. If there's a disaster, a fire damages part of the building, or if a tornado damages part of the building, we've taken the residents away from that immediate danger, gotten them down the hallways, gotten them past the fire doors. Or a tornado, maybe we lost a roof and we've gotten them off that upper floor. And so now what do? The fancy term is shelter in place. And what that really means is we're going to keep those residents in our building close to us, with the goal being so that we can provide the care for them that at the same level that we had been. So what goes into the decision to shelter in place? Well, there's a lot of things that go into that, depending on what type of disaster, how much of the building is damaged, or what the conditions are. We may be able to or may not be able to shelter in place, depending on whether we save up food and water for these cases, and perhaps that food or water was damaged, and we don't have the resources to shelter in place. That could also be a contributing factor. And also some of those decisions may not be ours to make. If FEMA or the emergency services crews get here and they decide that they feel the building's unsafe, they may make those decisions that we cannot. But we do have a lot of resources that may allow that to happen. We've got multiple buildings. We've got the Villa St. Joseph, Marymount Place, Clare Hall, and the convent. Villa St. Joseph has the Assisi Hall, which is a large meeting area that we can house people in if needed. The convent has a large chapel area. We have dining rooms that are fairly large that can accommodate many people. So these would be some of the options that we would look at if we were to shelter in place. So again, we look at the conditions that have been presented to us by the disaster and determine whether we can shelter in place. And this decision has a fancy name called surge capacity, meaning how many people can we house? Because it's not just our residents that we may have to house. We may have family member that show up that are going to be staying with their residents. We may have perhaps maybe the hospital was damaged more critically than us, and we may have to take in people from the hospital or from other local nursing homes. Again, we may have lost some resources. We may have lost the kitchen or some of our food or our ability to heat or cool the building. These are all things that would go into our decisions whether we could shelter in place or not. So the evacuation policy statement, you can read it, but again, it really encompasses the two main goals, which is first, we're going to protect and keep our residents safe. And again, that's just determined on what type of disaster we have. And then after that fact, we need to care for them at the same level that we were caring for them before. And if we can't do that in our facility, then we need to look at evacuating to another facility. So how is that evacuation order issued? Well, we started off by making those determinations that we talked about the building and our conditions, or whether the first responders have decided that they feel the building is unsafe. So we would start to make arrangements, start calling families, letting them know what's going to happen. We would start to call more staff in, because obviously this is a big task of moving all the people. We would set up what's called an incident command center, so that people could communicate in and out of there. They could set up chains of command with the other agencies to make sure that all these moves and all the things that have to happen to move residents can be accomplished. We do have contracts with other facilities, Marymount Hospital, South Point Hospital, and McCrea Manor in Alliance, that we have reciprocal agreements with to move residents either from our facility to theirs or from theirs to ours. One of the reasons we have all these agreements is, especially with the McCrea Manor, which is pretty far away, it's over 50 miles away, and we've done that in case all of our facility, our whole campus is perhaps damaged, and we wouldn't be able to move next door or even somewhere fairly local. So we have to have these contracts with facilities that are even farther away, so that we could move residents there if needed. So once the order is truly issued, again, we're contacting families. We need to set up transportation, and we also have put thought into, well, who would we move first? And we would start with the critically ill residents, or the residents that needed the most care and the most time to move. We would start with those residents, making sure they got the appropriate setups and transportation, and then we would work our way down the list to people who are more capable of moving on their own, perhaps, or needed less resources. Again, we would have more staff would be coming in at that point. We would be calling families and letting them know where their loved ones were being taken. We would be using cell phones or other available means to make all these communications. We also have these special forms that are in those disaster books, and those forms have a lot of information that we track, where they're going and their personal belongings, and they're very important to document all those things that the resident would need if they were moving to another location. And these are some of the things they would need. So we're required to give them a gallon of water if we're transferring them to another facility. We have to provide them with food. We have to give them clothing, obviously medical supplies, things like hearing aids and glasses, and all the things they would need if they were moving to another facility. These are all tracked on that form that we talked about earlier. And the idea is that so when they get there, they have this little checklist of things that they need, including their medical records, which determines the care that they need. So as far as medications, we're supposed to send a 7-day supply. I know that that's not always possible, especially with our system, the way our carts are set up, but that's the goal, and if possible, we would send them with a week's supply of medications. And again, medical records are very important. They're going to a place that doesn't know them. We would be sending a nurse with each group to each location. The nurse would be in charge of the records and the medications. But again, that nurse can't take care of 20 people, so there would be other staff that would need to take care of them, and they would need these medical records to know how to provide that care. We are also expected, without any kind of special circumstance, to maintain all of the HIPAA rules and regulations that are, and all the other requirements that are put down by CMS. We're not really let off the hook, in a sense, just because we've had a disaster. The only example is if the government provides a specific waiver during a disaster, and then if they provide this specific waiver, they do relax some of those rules. But up till then, we are expected to maintain temperatures in the buildings, same level, like I said, same level of care, and same medications, and all the other things that come along with HIPAA. Of course, power is a huge concern. Almost everything in our building uses power, from the heating and cooling systems to the computers that we use, to the printers, to blood pressure machines and the oxygen concentrators. Almost everything we have in the building requires electricity. We would need lights to continue to operate. So we have a lot of backups for that. We have a whole backup plan just based around power. We have multiple generators for the buildings. We have a system in place that if one of those generators didn't work, we would be able to get in a backup generator. We have to keep the food cool if we're going to be sheltering in place. So a lot of things depend on that power, and we have a pretty solid plan in place to make sure our building keeps the power on. So I'm going to let Dan finish up with the rest of the presentation, and thank you.
Thanks, Bill. So again, this is going to mean, with all we just learned, that we're going to be doing a lot of testing and training, a lot of unannounced drills. We've done this before in the past. We've done drills with elopement. We've done drills with active shooters. We are going to do a lot more of those. We're also going to work closely with community drills to train our staff for community-wide events. We've already done some tabletop drills with the local fire and with the hospital to learn how we could prepare better for these upcoming events if they were to occur. Disaster plan template. This is a means for us to really look at the organizational information here at our facility and look how we are going to be prepared. We're also, in that template, is also going to have a list of numbers. People that you could call in case we need help. People over at Trinity if we need to use Trinity. Or people at the convent if we have to use the convent and you're the one that is in charge when an incident occurs. When you get that book, it'll help you. We still have some work to do. We're still working on things like surge capacity here in the building to make sure that we evaluate the entire building and understand pieces and parts of it and how many people can go in each of those parts. Also, we have emergency backup plans with our power, with a lot of our suppliers have all been informed of these new policies and procedures that we had to put into effect. Emergency contact list, I just mentioned that, but included in that is Marymount Hospital, Trinity High School, Marymount Child Care, Villa St. Joseph, Marymount Place executives, external contacts including our food services, transportation, power, food, water. We have, as well as agency contacts and other emergency contacts, police, fire. So all those names and all those emergency tabs will be in there for you to reference. Emergency job tasks. Many of the staff here have been given job assignments. Those job assignments include calling families, making sure that medical records are prepared, making sure that we have food and water prepared, people contacting doctors, physicians, secondary ancillary services. Everyone has a job. They've been in service and trained on their job, and as people move through the process of it, we will continue to update them with any new changes we have as well. Those jobs can also be found in those disaster books. Incident command. Incident command is a means of setting up a hierarchy while we have a disaster. We can't have 100 people running around acting crazy. We do need to have some organization. And this is really why we have an incident command. Our incident command center will be located, if possible, in the second floor conference room in between Villa St. Joseph and Marymount Place. We will have an incident commander. We will have a medical and technical specialist, a safety officer, a liaison officer, public information officer, and so on. Each of these individual positions you see laid out in front of you have been given or assigned to a specific staff member, and they also have a backup staff member so that we can ensure that this will be covered. Collaborations. During QAPI, a new organizational structure was put together for us to understand that we may need to transfer patients. If the need arises that we have to transfer patients, we do have these collaborations in place. We have contractual agreements with them. We've already spoke a little bit that we have right next door as the transfer agreement, South Point, and we have a facility that is farther away, greater than 50 miles. During the collaboration, we also met with places like the Garfield Heights Police and the hospital to discuss how we would transport, how we would get individuals over, and our total capacity that may be needed.